right. Good morning, everyone, and welcome to today's academic meeting. So we will continue, as our blurb said, with our asthma series. It's actually the third part for those who attended the Pulmonology CME over the weekend. So last week, Prof spoke about pregnancy and asthma. Over the weekend, he spoke about ventilating the asthmatic patient or the difficult asthmatic patient. And today, we're going to delve into another different aspect of asthma, so the severe asthmatic, which only accounts for about 3.7% of the asthmatics we see, yet in terms of healthcare funding, probably takes a large proportion of funds, and also the largest amount of disability in terms of days taken off and days lost of productivity. I think Prof, as we all know, needs no introduction, but just to remind everyone that he's an emeritus professor of critical care and pulmonology, has numerous first author publications, first author and author in numerous chapters in international textbooks, and also received the Mandela Medal in 2024 for his service related to the care of Nelson Mandela just before his passing in 2014. So without any further ado, Prof, thank you.
Thank you. Thanks. It is a pleasure to be here again. I have the man who controls the money sitting right in the front row here, so I have to persuade him that the agents we're talking about are definitely ones that we need. And I'm sure you're already convinced, not so great. Right. Okay. So now it doesn't work. All right. And that doesn't work.
Yeah.
Okay, let's see. Then that works. All right. So as we discussed last week, in fact, if you don't have asthma at the moment, it doesn't mean to say at some point you might not develop asthma. And the point is that it's a result from an interaction between genetic predisposition and also then something in the environment which will then cause that asthma to manifest. And then it's driven by specific molecular mechanisms, and we call those endotypes. Then the way it actually presents is a phenotype. So you've got genotypes, endotypes, and phenotypes in terms of the way we look at the asthma patients overall as well. I showed this last week, but it's particularly relevant in terms of what we're talking about now. We are talking about the Th2 type inflammation over there and the non-Th2 type over here. This still remains the most common, fortunately, because it is actually susceptible to therapy and to inhaled corticosteroids, but the effector cells are things like the B cells, the mast cells, the eosinophils, all of those types of cells that we used to dealing with in terms of atopy in particular. And if you look at non-type 2, this is initiated by irritants, by pollutants, things like cigarette smoking, viruses, microbes, etc., can initiate it, and the effector cell is in fact the neutrophil, and the neutrophil is relatively unsusceptible to inhaled corticosteroid. So if you're going to have asthma, you would prefer to have the Th2 type because you're more likely, therefore, to respond to therapy as well. And I'll go back to the GINA track 1 therapy initially, where in fact we've done away, I shouldn't say we, but we now should be as well, have done away with, in terms of asthma, with the short-acting beta agonist, because you ought to be using a combination inhaled steroid and long-acting beta agonist at the same time. So rather use an agent that has a rapid onset and you get a dose of steroid at the same time in order to ensure that you are treating that underlying inflammation. And you would then increase your dose of corticosteroid until you get to this point over here, where you then add a long-acting muscarinic antagonist as a potential treatment. We don't yet have a long-acting anti-muscarinic antagonist because the NEMLC, the National Essential Medicines List, actually does not feel that they are of any value whatsoever, which is obviously nonsense, and it's very difficult to persuade them otherwise. But after that, you might try even higher dose steroid, but that just causes side effects. You would then look at other options, and that includes the biologic agents that we'd be looking at there. And that would then be exactly the same in terms of the track 2, where you're still using a SAVA, but you take inhaled steroid at the same time, and the same actual intervention thereafter if you still don't have adequate control as well. So as Viv mentioned, it actually occurs commonly, severe asthma. These are patients that don't necessarily respond immediately to the therapy we're utilizing. 3 to 10% of the total asthma population overall. Severe asthma would be uncontrolled despite adherence to optimized high-dose inhaled steroid and long-acting beta-agonist therapy, and then treatment of contributing factors, which are often forgotten, such as the allergic rhinitis, such as exposure to ongoing allergens, such as a gastroesophageal reflux, etc., taking of aspirin, whatever. All of these things one has to look at in order to treat them appropriately as well. And we'd say that you're uncontrolled if you have greater than or equal to one of the following. For poor symptom control, and there you would use varying scores. You'd be utilizing the ACQ or the ACT. These are various asthma scores. And you would be on your NHLBI guidelines, etc. And along with that symptom control, you're having frequent severe exacerbations requiring oral corticosteroids or admission to hospital as well. You've got definite airflow limitation, and you have controlled asthma that worsens on tapering your inhaled steroid or your corticosteroids. So oral corticosteroids. So they're dependent upon oral corticosteroid use as well. And this is what Jean is talking about in terms of management of those patients. You're going to look for all those factors that I mentioned there already. There are multiple. And just by the way, one I didn't mention is cigarette smoking. And that means also side stream tobacco smoke. It also has a significant impact on asthmatics if they're living in a home where there is cigarette smoke in the environment as well. So you look at all the other factors that are contributing as well. You then have to get serious in terms of education.
If you could discharge him.
Somebody is telling us about their discharge. What's good? You need to discharge. So education, you've got to optimize treatment. Patients don't use their inhalers correctly. You would think that they actually would all know. But when, in fact, doctors are asked to demonstrate how to use an inhaler, even they are not particularly clued up in terms of the actual technique of using those inhalers as well. Consider the non-pharmacological ones: smoking cessation, exercise, weight loss. Weight loss is an important one because it also contributes to the severity of asthma. Mucus clearance, physio, in other words, and obviously vaccines as well, which is obviously interesting because the Kennedy and people like that are busy saying that vaccines are not a great idea, but really we're seeing the consequences of not vaccinating children. Treat the comorbidities and risk factors, and then consider the non-biological add-on therapy, LABAs, LAMAs, the muscarinic and leukotriene antagonists, and consider a trial of high-dose inhaled steroid and LABA. So if we then look and see that if despite all of that, is the asthma still controlled? Well, yes. If uncontrolled, yes. Then we'd say they've got severe asthma. You would restore them to their previous doses of what they're using. And then does the asthma become uncontrolled when the treatment is stepped down? If yes, we go back to the previous dose over there. And then if they are controlled, you continue optimizing the management as much as you possibly can. In other words, you're trying, excuse me, you are trying to avoid the necessity of going on to the use of a biologic agent because they actually are very expensive. And you then need to actually determine the phenotype. Is it a Th2 type or is it the Th1 type, which is the neutrophil? If it's the Th2 type, we'd be looking for blood eosinophils that are more than 150 microliters, or FeNO, and we do have access to one of those. The FeNO is the fractional excretion of nitric oxide. Remember, that is an inflammatory is excreted as a consequence of ongoing inflammation. So it is a marker of inflammation in itself. Sputum eosinophils that are more than 2% and or the asthma is clinically allergen driven, and you know what the allergen happens to be. And you would repeat these up to 3 times, at least 1 to 2 weeks after oral corticosteroids, because if you take oral corticosteroids, your eosinophils disappear. And that is one of the major problems in terms of identifying the Th2 type as well there as well. So you would then do it at least 1 to 2 weeks after oral corticosteroids or on the lowest possible dose. But even the lowest possible dose may inhibit the production of eosinophils. If you've got no evidence of type 2 inflammation, then there is a different approach that one might use. And I'm not really going to go on to that at the moment, because fortunately, those patients are not as common as one might expect. This type is the type that is particularly common there as well. So if the patient could have type 2 inflammation, yes, the type 2 inflammation, you then consider whether they are adherent to their therapy. And remember, within asthma and probably within all other treatments, patients are notoriously non-compliant despite insisting that they are actually taking their therapies as well. And then you consider, as I mentioned, the non-biological treatment for specific phenotypes. The aspirin-exacerbated respiratory disease, about 5 to 10% of asthmatics, and they have nasal polyps, etc. You can avoid those. Allergic bronchopulmonary aspergillosis, which occurs particularly in the Cape. We see it less because we drier up here in Johannesburg. We do see it actually in patients with cystic fibrosis.
How are you?
Those patients with cystic fibrosis have sensitivity to aspergillus, and then things like chronic rhinosinusitis, nasal polyposis, etc. And then you say, is the type 2 biologic therapy available or affordable? And of course, if not, well, then you have to try other things, and you're looking at LAMAs, your leukotriene receptor antagonist, azithromycin as an immune modulator, and as a last resort, add on low-dose oral corticosteroids, but you try to minimize side effects like, in fact, bone osteoporosis, etc., and stop ineffective add-on therapies if they make no difference. If you do have one available, well, then you consider going on to utilizing a biologic agent, and you would have to pick a specific one based upon the phenotype that you actually are dealing with. And the first of these that became available is omalizumab, and this was actually licensed in 2005. It was the first monoclonal antibody that was approved for severe asthma. It binds free circulating IgE, it inhibits attachment to its receptor, and it diminishes the downstream effects, including mast cell degranulation and the cytokines IL-3, 4, 5, 6, and 13. And it inhibits both the early and the late allergic responses. Remember that if you are well and you are allergic and you are exposed to an allergen, you will get an immediate response. Then you will, in terms of your airway closure, then you will gradually improve. And when all those inflammatory cells move into the airway, then you get a second drop in your FEV1. So that is the late response, and it's related to the inflammation within the airway as well. It does reduce acute exacerbations, hospitalizations, ED visits, and the inhaled corticosteroid dose. And a 2014 Cochrane review from 10 studies reported an overall risk ratio of 0.55, in other words, a 45% reduction versus placebo for the annual exacerbation rate. If we look and see where omalizumab works, there are the IgEs, and it works. There is your Th2 type response down to the eosinophils. There is your Th1 type response. And as you can see, it works specifically there on the IgE, inhibiting the B cell production of IgE thereafter in allergic asthma in particular. So It has been shown to have benefit as add-on therapy in severe allergic asthma, and you have to confirm that with real-life observational studies showing that there is a specific allergen to which you actually are allergic itself. The largest study showed modest efficacy in more than 3,000 of these patients, but 42% still had exacerbations, just more than 2 exacerbations or equal to, despite omalizumab, versus 63% prior to therapy. So the exacerbations number went, or not the number, but the people who were having greater than or equal to 2 went down from 63 down to 42%, which is still a major problem. You're really not controlling the number of people who get ill as well. And 20% had greater than or equal to 4 versus 48% prior. So about a halving, but still large numbers as well. And these ongoing exacerbations actually highlight the treatment limitations. So for omalizumab, what are the actual factors that would predict that you are likely to respond to this agent? You have to have allergic asthma and demonstrate an allergen. The actual prescription is based upon IgE. And this is silly because, in fact, there is no relationship between IgE and the likelihood of you actually responding. So neither allergen-specific IgE or total IgE predict the response. And it may even reduce acute exacerbations in non-atopic patients. The two T2 biomarkers that reflect inflammation, FeNO, as I discussed before, and blood eosinophils do relate to its efficacy, much like many of the other agents as well. And it's ineffective if your eosinophils are less than 260 and the FeNO less than 20 parts per billion that one can measure on the actual device itself. It's only licensed in allergic asthma, as I said. You need to have a reduction in your FEV1. You need to be having greater than or equal to 4 acute exacerbations per year, despite high-dose inhaled corticosteroid and LABA, or you need to be having a maintenance oral corticosteroid. Subcutaneous injection given 2 to 4 weekly, and the dose is determined by weight and IgE. And again, this is completely silly because the IgE does not predict whether you're likely to respond or not. And if you are large and your weight is high and your IgE is high, then if you get a value of more than 1,500 international units as a consequence of those two factors, then you can't give it. And that applies to very many of our patients overall anyway. They're pre-filled syringes of 75 and 150 milligrams. So the highest doses require 4 injections every 2 weeks. So certainly not a very easy one to actually use. So mepolizumab is also another one that's been available. It's licensed for severe eosinophilic asthma rather than specifically allergic asthma. It targets interleukin-5. Interleukin-5 is critical for the development and the migration and survival of eosinophils, and mepolizumab significantly reduces both blood and airway eosinophils as well. In the Mensa study, their inclusions were eosinophils more than 150 at screening or greater than 300 in the past 12 months, and you should be having greater than or equal to 2 acute exacerbations in the prior year. This study showed a 52% reduction in acute exacerbations and in the oral corticosteroid dose versus placebo. The baseline eosinophil count and the exacerbation rate were the only factors influencing efficacy. And if you actually were, I say lucky enough, but if you were lucky enough to have an eosinophil count of more than 500, then your acute exacerbations were reduced by 79%, and the FEV1 also increased significantly, and your symptom score increased significantly there as well. So if we look at the mepolizumab, there it is, acting on IL-5, and it specifically is important in terms of the migration and recruitment and functioning of your eosinophils, And that's why it benefits those patients very specifically. The Sirius study, their inclusion criteria were that you must have been on daily oral corticosteroids. Again, eosinophils more than 300 or greater than 150. And this should be in an oral corticosteroid dose optimization phase. And at 24 weeks, 14% of them stopped oral corticosteroids with an overall median reduction of 50% in terms of the dose of corticosteroids, but 30% on placebo in this study also reduced their oral corticosteroids by 50%. So, I mean, this is a problem because it just indicates that they hadn't optimized the dose of corticosteroid before this study actually started. So it actually detracted from the apparent benefit of this study as well. Despite oral corticosteroid reduction, acute exacerbations were significantly reduced with an annualized exacerbation rate of 1.44 with mepolizumab versus 2.12 with placebo. So not quite 50%, but almost 50% as well. It's a fixed dose. It's given 100 milligrams every 4 weeks subcutaneously via a pre-filled syringe for self-administration. Patient can give it at home, and it has very good safety data up to 4.5 years. So the one that we actually have had some access to is the benralizumab. It binds directly to the interleukin-5 receptor. Remember, the MEPO bound to the interleukin-5. This binds to the interleukin-5 receptor on eosinophils with antibody-mediated recruitment of natural killer cells and eosinophil apoptosis, so that you end up with 0% of eosinophils in blood and a 96% reduction in eosinophils overall. That was a bit of a concern. It felt that maybe people might develop cancers as a consequence, or that people might be susceptible to parasitic infections, but that does not seem to be the case. So there's the benralizumab. It binds to the anti-IL-5 receptor. So where the IL-5 binds, it binds to that and prevents the action of the IL-5, which, as we said, is important for eosinophil function there as well. There have been a number of studies, Sirocco, Kalima, and Bora. And if one actually looks at the crude annual rate of exacerbations, and by the way, the dose for the first 8 weeks, you're going to be giving the dose, the first 3 doses are given 4 weekly, and thereafter the dose is given every 8 weeks. So it means that it is the least amount or least frequent injection that you actually need to administer there as well. And as you can see, that their annualized exacerbation rate dropped in Sirocco from 1.53 to 0.66, more than half, from 1.03 in Kalima to 0.66. And this was a continuation study, the Bora, in which from these studies, they continued on in an open label fashion, and they were able to show that the exacerbation remained at 0.57 and then remained at 0.46 in those that had continued and those that were added new to the benralizumab there as well. So a good maintenance, ongoing effect. And here you can see from 0.66, 0.66, and on continuation, it actually even continued to drop in terms of the number of people having them. And if we look at Andy, and this is now looking at patients with eosinophils of more than 150 or eosinophils greater than or equal to 300. If your eosinophils are greater than or equal to 150, you get a 49% drop. If the eosinophils are higher, you then get a 59% drop in the acute exacerbation. So obviously those patients with more eosinophils are the ones most likely to respond effectively as well. Predictors, therefore, of response are high baseline acute exacerbations. This is the annualized exacerbation rate. Higher blood eosinophils. Nasal polyposis indicates an allergic diathesis, and often sometimes the aspirin exacerbated asthma. Low baseline FVC, less than 65%. Oral corticosteroid dependence, and then real-world data subsequently confirmed these associations as well. Baseline FeNO, IgE, or co-eligibility for omalizumab are not. So in fact, they don't really help you to do those. Primarily exacerbations and eosinophils are going to be the indications for these patients to use this agent as well. Approved in South Africa for greater than 8 years. I think it's about 10 in Europe and the US. It's a fixed subcutaneous injection given 4 weekly times 3 and then 8 weekly, least frequent dosing. More than 8,000 patients have received it, no signals of harm, including no increased infection or malignancy. And the Meltemi studies evaluated it up to 5 years as being a safe agent to use there as well. Now, dupilumab has performed a number of studies and obviously is one that is of benefit as well. It targets the alpha subunit of the interleukin-4 receptor, and that's a ligand for both interleukin-4 and 13, and decreases signaling of these key T2 cytokines, reducing FeNO and total IgE, while the actual eosinophil count initially rises, and then it actually drops thereafter as well. So you see an apparent elevation initially, which is surprising, but then it actually drops as well. And there's the dupilumab. There are the IL-4 and the IL-13, and those actually would activate your B cells along with the production of IgE, and it works at that point over there specifically. There have been a number of studies, Liberty, Asthma, and Quest, 1,902 with greater than 1 acute exacerbation, irrespective of eosinophils or FeNO. They could be on medium or high dose inhaled steroids. So in other words, less severe than the anti-IL-5 or IL-5 receptor trials, because they only had to be on inhaled steroids and not on oral corticosteroids as well. And also only 1 exacerbation. There was an overall annualized exacerbation rate reduction of 48%, significant benefit only with eosinophils of more than 300, and in that setting, the exacerbations fell by almost 66%. There was no statistical benefit in this study with counts less than 300, and there were improvements in lung function, and not only that, if you had high FeNO, you actually got the greatest improvement of lung function up to 300 to 390 mils there as well, indicating again significant benefit in terms of patients who have inflammation-driven asthma as well. The Venture study showed an overall reduction of oral corticosteroids by 50% versus placebo, and 69% reduced their dose to less than 5. Now, the important point there is that most patients, or many patients, were left on 5 in order to avoid Addison's disease. So it didn't necessarily mean that they needed it for their asthma, but they didn't want to just take it away because many of these patients had been on corticosteroids for a very prolonged period of time. And this was versus 33% with placebo. The marked placebo response also, as I mentioned in the previous study, detracted from the perceived benefit, because if they also got better, 33%, it implied that many patients were on oral corticosteroids unnecessarily, and therefore it becomes a bit difficult to say that they definitely need the drug if you haven't shown that they get worse when you remove the corticosteroid dose. The actual corticosteroid reduction occurred with low, that's less than 300 cells, and high, but the greatest benefit, again, was seen with the higher eosinophil count. And Traverse, which was moderate to severe asthma in adults and adolescents, had persistent improvements in clinical efficacy for up to 148 weeks. Vestige is a study that came out this year already. Primary endpoints with the proportion of patients with a FeNO that had reduced to less than 25 parts per billion, and also a percentage change from baseline in airway volumes. In other words, they were able to show on CT scan that there had been an increase in the airway volume related to the removal or decrease in mucus plugs. Again, looking at the inflammatory component of the asthma as well. And it reduced airway inflammation, mucus plugging, and improved the volume as well, along with the lung function and the asthma control. So it's approved for ages of greater than or equal to 12 years. The European Medicine Association requires evidence of T2 high inflammation, eosinophils and FeNO. The FDA says also for use in any oral corticosteroid dependent patient, regardless of baseline blood eosinophils. I suppose that's practical because almost all of these really difficult to control asthmatics are on oral corticosteroids, and looking therefore at eosinophils is extremely difficult because you have to remove the steroid, then they get worse, then you've got to recontrol them, then you've got to add your biologics, so it becomes very awkward as well. It's given 2 weekly as opposed to 8 weekly for the benralizumab, fixed dose as a pre-filled syringe. Just very briefly, the tezepelumab, which is not yet available, so it targets the epithelial alarmin, TSLP. It's released following pro-inflammatory stimuli and is related to T2 cytokine expression and asthma severity. It occurs earlier in the inflammatory cascade than all of the others, with theoretical benefits for broader effects and possibly also in that category of patients with Th1 inflammation. And it decreases T2 biomarkers, eosinophil count, FeNO, and total serum IgE. So if we look, there's tezepelumab, right up here, there's TSLP over there, and you can see there's a potential for an influence both in the Th2 group and also in the non-Th2 group over there. And that will be a great benefit because these are particularly difficult patients to treat. So if we're going to summarize those, you've got across the top, you've got omalizumab. Oops, somebody's hidden my thing. You've got the mepolizumab. This one has not yet been launched. It's also an anti-IL-5. Reslizumab, benralizumab, and dupilumab. As you can see, they are best in patients with elevated eosinophils. They say 150 for tezepelumab. FeNO, only really in omalizumab over there, and also in dupilumab and in tezepelumab. They would be agents that are important, not important in terms of the one that we might get access to, the benralizumab. The exacerbation rate reduction, 25%, 50%, 40, 50, and 70% for dupilumab. But do remember that study was also had significant reductions in the placebo group and doesn't necessarily mean that that is better in terms of the other agents that we're looking at. A mean oral corticosteroid reduction, significant in these two over here. Quality of life improvement in all tezepelumab in the early studies, perhaps the most. And it also treats comorbidities, the chronic rhinosinusitis with nasal polyposis. Dupilumab has a good big study, and another one relatively recently of benralizumab in that setting as well. Even, in fact, diseases like EGPA, is eosinophilic granulomatous polyangiitis, can also be treated with these conditions as well. And the frequency, as I've mentioned, 2 weekly, 4 weekly, 8 weekly, 2 weekly, 4 weekly. And of course, that makes a benefit in terms of compliance in these patients here as well. A recent meta-analysis of biologics as a whole, not looking at individual or specific ones, 48 studies with 16,000 patients overall. They had a 44% reduction in annualized exacerbation rate, obviously therefore a rate ratio of 0.56, and it was significant. 60% hospital reduction rate, a mean increase in FEV1 of 0.11 liters, and also a reduction in the ACQ score, which was a one indicated control, by 0.34 as well. And what they did note was that there was heterogeneity between the different agents. So one will benefit a patient more than another one, and then in the next one will be benefited more by the other one. So there is heterogeneity there as well, but overall greater efficacy with T2 inflammation, which is what we've been pointing out throughout. So basically what you should be looking at, anti-IgE, which is specifically omalizumab, what factors predict good response, blood eosinophils greater than 260, FeNO greater than 20 parts per billion, allergen-driven symptoms, you must show your allergen, childhood onset asthma over there. The anti-IL-5 or anti-IL-5 receptor, benralizumab and the mepolizumab, the factors predicting a good response are going to be eosinophils higher, more exacerbations previous years, adult onset nasal polyposis. The anti-IL-4 receptor, the dupilumab, this would be higher eosinophils and higher FeNO. And when we look at the TSLP, which we don't have as yet, the response again would be higher blood eosinophils and would be higher FeNO as well. So basically, you choose one if they're eligible. If you get a good asthma response, then you would extend the trial to 6 to 12 months. If you don't get a good response, then you would stop and the add-on, and you would consider switching to a different type if you had one. If you don't have one, I'll show you now. If you've got a good response to the T2 targeted therapy, this would be the patients with have a good response. We still reevaluate every 3 to 6 months. You consider decreasing or stopping your oral steroids and checking for adrenal insufficiency before you stop them. And then consider other add-on medications as well. If the asthma is well controlled for 3 to 6 months, consider reducing the maintenance inhaled steroid LABA dose. Do not stop it at any point because they will recur thereafter. Reevaluate the need for ongoing biologic therapy. And recent studies actually looked at increasing the dose interval in those patients who've got complete control and have shown up to 156 months that there has been an improved benefit or maintained benefit as well. The order of reduction of treatments is based upon the observed benefit, side effects, and patient intensity. If you've had no good response whatsoever, you stop the biological therapy. Review all of your basics in terms of what I've mentioned before, inhaler technique, compliance, comorbidities, etc. Consider high-resolution CT to make sure you're not dealing with some other disease like EGPA or something. Reassess the phenotype, induce sputum to see what cells you actually get. Consider add-on low-dose azithromycin. Consider bronchoscopy for alternative diagnoses. And as a last resort, consider add-on low-dose oral corticosteroids. And then consider bronchial thermoplasty, which, as far as I know, is still only performed in Cape Town, where you actually are probably decreasing vagal stimulus. It's not so much the fibrosis that they do when they heat the airway. Always sounds a bit frightening to me. You put down your bronchoscope and then you heat the airway, and that was felt would cause fibrosis, which would prevent the inflammatory component and also would decrease the ability of the muscle to contract. Probably, though, it's related to an effect on vagal mediated bronchoconstriction. And stop ineffective add-on therapies, but never stop the inhaled corticosteroids. So we do have new agents available to us in this dreadful category of patients that all of us manage. Not a huge number, but when you do have them, the use of resources is excessive. And merely to control them, even if it is an expensive agent, may well decrease the expense that you have in those patients individually. Thanks very much.